One. Recording is started, sir.
Good evening, all. We are back after a small hiatus for the much awaited master classes by Abha Majumdar ma'am. The topic for today is duostim, a relatively newer protocol in IVF, regarding which everyone has many questions in their minds. So, ma'am will throw light on this topic today. Over to you, ma'am.
Thank you, Bhavani. This is really the burning topic today in the world of IVF, where we are trying to address poor responders for which we have very few answers. And if we have, they are so diverse that we really do not know how to stimulate these patients, how to counsel them, and what is the way forward. So I'm going to talk about duostim, whom, when, and how do we do it. Dual stimulation, in short, is called as duostim. Duostim means two controlled ovarian stimulation cycles for IVF within one menstrual cycle, which means within 30-32 days, with the purpose of maximizing oocyte and hence embryo collection in a shorter period. It is used in cases undergoing controlled ovarian stimulation for IVF, where we anticipate that we may not be able to obtain adequate number of oocytes by one stimulation to achieve a live birth. Now, suppose you stimulate a patient once and you get 2 or 3 oocytes, you make one day 3 embryo, you don't reach a day 5, or you make one day 5, you transfer it, and it is negative. The patient will take months to get back to you for another stimulation. I mean, she just undergoes so much depression, and hence this protocol was thought of. We all understand that recently, since a decade, there has been a change in the concept of how a menstrual cycle is connected to a ovulatory cycle. Recent evidence on physiology of follicular recruitment suggests that recruitment is by multiple wave theory within every menstrual cycles. So there is a ovulatory wave, and because there is ovulation, the pituitary hypothalamic axis is suppressed and only one ovulation happens, and there is a luteal phase which will sort of support a pregnancy. Suppose that ovulation does happen, but can we stimulate another wave of ovulation in the same cycle? Yes, this is what this implies, that 2 to 3 cohorts of antral follicles are recruited and are available for stimulation in a single menstrual cycle, both in follicular and luteal phase. You must have heard about random stimulation protocols. Patient comes to you on day 8 and says, I have to go through cancer therapy and please collect my oocytes. Will you tell her that you come back on day 2? No, you cannot do that. We start stimulation on the same day. You give her 5 days of gonadotropin and you see maybe she's ovulated or she's about to ovulate. Let her ovulate, continue the gonadotropin, and maybe another 5 days you will have a good cohort of newly growing follicles. But there would be progesterone in her system. There would be progesterone in her blood. And we understand that the PPOS protocol, that is progesterone primed ovarian stimulation protocol, is based on this, that we can give progesterone while stimulating a cycle. And the presence of progesterone doesn't reduce the competence of eggs, nor it changes the embryo quality. So this concept is different from the previous understanding that follicles grow only during follicular phase, and once the recruitment happens, naturally they will only grow in the follicular phase. And once the recruitment of dominant follicle happens, it will follow exactly what we had learned, that the FSH is slightly suppressed so that the other follicles of the cohort are suppressed, and one follicle which reaches dominance will go up to ovulate and then create a pregnancy. But now we can play with these medicines, and we can at any time initiate a cohort of follicles to grow. So what are the main features of duostim? It is a newer ovarian stimulation protocol used for controlled ovarian stimulation in IVF only. Only IVF, because here when we stimulate multiple times, then the endometrium is all confused. it cannot implant an embryo. So we just overlook the endometrium. Endometrium is a different area, a different part where the endometrium is growing. So we don't even look at the uterus. All we are looking at as the ovary. We have separated the uterus from the ovary, and we go on stimulating the ovary with the aim to collect embryos. And this is especially for women who have poor prognosis, who enter the IVF program with low AMH, with high age, or where earlier IVF has produced very little eggs despite having a reasonably good AMH. This method combines consecutive stimulations in follicular and luteal phase of a single ovarian cycle to maximize number of oocytes, hence embryos which can form within a cycle. The only thing is that all these embryos need to be cryopreserved in Diostem protocol. Why? As I told you, the uterus is running at its own pace. It is getting a taste of progesterone, taste of estrogen rising. So it is not fit for implantation. Hence, we need to cryopreserve, and therefore we have no option of fresh transfer. All embryos are transferred in subsequent frozen thaw embryo transfer cycles only. Now, which are the patients when we consider Diostem? Most important section is poor responders, and looking at the Poseidon analysis, we found that this was Sandro Esteves who brought out this analysis in 2021, that almost 40% of women who come to IVF belong to Poseidon group of poor responders. So either they are low age, low reserve, or low age with poor response in the previous cycle, or they are of higher age, which means over 35, with poor ovarian reserve or poor response in the previous cycles. So Diostem can also be used in cycles where you had adequate eggs, but your embryologist tells you on day 3 there is nothing, or tells you on day 5 there is hardly any embryo. There also we can go for Diostem. So if the embryo conversion is inadequate, then we can do Diostem. And I'll tell you, patients are so motivated when they hear, or when you counsel them from the beginning, that we will collect embryos so that we have embryos for 3-4 cycles. You don't have to undergo any more stimulation. We will transfer 1 embryo at a time, or maybe 2 embryos at a time, depending on the center's implantation rate. And you will have 3 chances of implantation in the subsequent 3 cycles. They are very happy to go through this. Then there is another very important indication which has emerged for Diostem, and that is when we have contemplated pre-implantation genetic testing. Like I taught you in the genetic PGT class, that genetic testing is for IVF patients, and it is also for patients who get pregnant very simply, go to obstetricians, and then we find underlying abnormality in the form of recurrent abortions, where we could find chromosomal structural translocations, or there could be monogenic disorders, and the baby born previously shows a genetic abnormality which is not compatible with normal life of that child. And hence, PGTM and PGTSR for monogenic disorders, and structural reformations. And the other one is when high age women are going in for IVF, they have a reasonable reserve, yet they want PGTA for aneuploidy to be done. Then we can offer them a Diostem, that, okay, we'll collect many embryos and we will go on taking biopsies, freezing them. And when we have, because we all know women who are over 39 years of age till 42 years of age will have 20% of euploid embryos. That means for every 5 embryo, only 1 will be a euploid embryo. So if we want to collect these, we need lots of embryos. And hence, Diostem is a preferred method of controlled ovarian stimulation. And last is fertility preservation. But then, like I told you earlier, Diostem for fertility preservation in cancer patient awaiting surgery or chemo or radiotherapy, if they have at least 1 month to undergo 2 stimulation cycles, we can start a random start and take up 2 stimulation cycles. But ideally, if they have very little time, just 2 weeks is given to us for collecting oocytes, then they go for just a random start protocol, which generally ends within 2 weeks. And we can start at any time of the menstrual cycle. And I tell you, you do it and you will get good results. Whether you start it 4 days before you are thinking ovulation will happen, or 6 days before, or in the luteal phase. So, how do we do diostim? Various regimens have been described in studies which have been published. We've done extensive review of the whole literature. Diostim started in 2012-13 by Kwang et al. And since then, a lot of workers have experimented with Diostim. A lot of studies have come up. We've analyzed each and every study from then onwards. So there are differences in stimulation protocols, that means COH. There are differences in method of LH suppression. Then there are differences in type of trigger. And there are differences in the gap days between one oocyte retrieval and the start of other stimulation. And the gap days could vary from 0 to 5 days also. Look at the stimulation protocol. So there are two main stimulation protocols which have been undertaken for these women. And when mild stimulation protocols are taken, they are generally for high age, very poor reserve patients, where a lot of workers have found that giving a lot of drugs may not help. They will in any case make one or two oocytes only, and hence they like to use mild stimulation. Kwong et al. In 2014, as I told you, was the first to describe double stimulation, and it's also known as the famous Shanghai Protocol. He used mild stimulation, alternate days, HMG, some letrozole, some clomiphene, everything. Following this, many other studies used mild stimulation protocols in FPS and in LPS, or in one of the two phases, maybe in FPS, but not in LPS. And I'll show you a table where I've given all these studies. Then comes the era of conventional stimulation protocols, and this was started in 2016 by Ubaldi et al. He was the first to describe conventional stimulation in diostim in both the phases, follicular and luteal phase. And in most subsequent studies till date, including ours, which has been published, conventional stimulation protocol has been used. I'll tell you a small difference between mild and conventional stimulation protocol. What is the mindset? My mindset is that if I give them a light stimulation, I will be able to stimulate whatever little antral follicles have already surfaced up. But if I give them a heavy gonadotropin stimulation, being exposed to that dose, many antral follicles which are under the surface might also become gonadotropin sensitive and may emerge, and they may be in the cohort, maybe the 13, 14, 15, or maybe 12 millimeter follicles, which also yields eggs when we give them exposure of 10, 12 days of gonadotropin followed by HCG trigger. So that is why I brought this, that although mild stimulation using clomiphene and or letrozole with intermittent gonadotropin has been described for poor responders, evidence does not support their use due to what happens. There is increased risk of cycle cancellation. You use small doses and maybe one follicle grows and you find no egg in it, or maybe, nothing grows. So there are lesser number of oocytes for sure, and cycle cancellation rate is high. For this, you can go into a publication which was mm, uh, by the group of Dr. Sunkara, and they did a huge HIFA, with the HIFA data, they did a huge publication in natural cycle IVF plus mild stimulation cycles as well as conventional. And they found that in the mild stimulation or natural cycle, they needed 3 to 4 times more cycles to get those number of embryos which they could get in conventional stimulation. So these are the few studies starting from Kwong et al. I could find where duostim studies which use mild stimulation. If you see the FPS protocol, you will see in Kwong et al. Clomiphene citrate from day 3 to prior to trigger. So what did they use for suppressing LH surge? They used clomiphene citrate. They gave it continuously till trigger. Then even letrozole was given for 4 days. Then HMG was given. So they, sort of mixed and matched a lot of drugs. LH suppression, again in the luteal phase, was done by CC. So Zhang et al. Also used clomiphene citrate till trigger day. We have done a study from our center, Dr. Ruma has done it, where we've given clomiphene citrate to donors from the start of stimulation till the trigger day. And this clomiphene citrate has blocked the surge of LH. So, uh, all these studies show using clomiphene citrate with letrozole, without letrozole, and small doses of gonadotropin. And when you see the results, well, Kwong et al. Said significantly more oocytes retrieved in the luteal phase stimulation versus follicular phase stimulation. And if you ask, I will answer this question. Then again, Zhang et al. Said significantly higher number of oocytes, embryos, and implantation rate with LPS compared to FPS. Then Rashitin and Zhang said similar number of oocytes in FPS and LPS. And then the last one was Madani et al., which said embryos were higher after FPS than LPS. So Madani study said that follicular phase stimulation was better. Rashitian said both are equal, and Zhang and Kwong both said that higher numbers were seen. Now I come to Diostim using conventional stimulation protocol, where Ubaldi started the ball rolling with this 2016. Here, the only thing was that they gave only a GnRH agonist trigger. And why did they give a GnRH agonist trigger? So that luteolysis happens earlier in the next cycle, and they can get a clear ovary by the time they start monitoring. So Ubaldi, then Alsberg, then Leo et al., Bodon et al., then Verily, who's from the group of Ubaldi only. And then our paper was published last year. Was it last year or this year? 2023, yes, last year. So all of us, Ubaldi said definitely luteal follicular phase and LPS increased chance of obtaining one euploid blastocyst with diostem in the luteal phase. Then Alsberg said significantly higher oocyte number, but similar number of embryos with LPS. Diostim is a valid option to FPS only, decreasing risk of cycle cancellation. Then Liu et al. Said similar number of oocytes in FPS and LPS, performing Diostim doubles the number of oocytes when compared with FPS only. Borden et al. Said significantly less number of oocytes with LPS. So there were studies which had less, but then this study has a very small number. If you see, Liu et al. Had a big number. And then came Verily with the largest number, 827 number of patients. They got sort of encouraged after Ubaldi's paper, and the protocol was same in both the sides. LH suppression was done by antagonists like you do in your normal single stimulation, and they concluded that there were significantly higher number of M2 oocytes with LPS. Blastulation and euploidy rates were comparable between FPS and LPS. Patients with at least one euploid blastocyst increased from 42.3% to 65.5% with Diostim when compared. So compared with FPS only. So there was a very encouraging paper, and that is the time when I also started Diostim in my center. And this was just around COVID. I started in 2018 truly, but then we had less numbers. After that, we went on to higher numbers, and we did 118 cases where we found significantly more number of oocytes in LPS versus FPS. And 69% of our cycles were rescued by doing LPS, where no embryos were formed in FPS. So having told that, methods of LH suppression, well, one can use antagonist like you use in the normal ANTAG protocol, or you can use progesterone primed ovarian stimulation, because you don't have to do a fresh transfer. So you can sort of rule out with the antagonist totally, or you can give.
Ma'am, sorry to interrupt you.
Yeah.
Can the entire team please check, ma'am? Actually, there are lines coming on
Yeah,
the.
there is someone who's scribbling on the screen. I
Yeah.
can see that, but I didn't say anything because someone's child is playing with the screen. I would be
Can
very
the entire
grateful.
team clear this?
No, they will not be able to clear. I will have to switch it off and switch it on, and then only it will clear out. Let me see if I can do anything to this. No, I can't do anything to this. There's some child who's scribbling on the screen. This happens even in our classes when we do our classes. So, anyways, don't look at the lines, just blind yourselves from the lines. This is what I was trying to do. So, you understand that progesterone primed ovarian stimulation is a very good strategy. Uh, and if we use it during LPS, it not only prevents premature LH surge, but also avoids the happening of menses before or during oocyte retrieval. Because if we give a GnRH agonist trigger in the follicular phase, menses may happen by the 8th, 9th, 10th day. And maybe if your patient is ready for a oocyte pickup, then she would be continuing to menstruate maybe by day 13 or 14 of the cycle, where she could still have some menstrual bleeding. So ours is one of the very few studies to use medroxyprogesterone acetate 10 milligrams per day in LPS to suppress LH. So this also precludes the use of antagonists to control the LH surge, reducing the number of injections in LPS, improving patient compliance and decreasing treatment cost. I'll tell you why we did not use it in the follicular phase stimulation. So this is our stimulation protocol, which is published also, and dual stimulation IVF, Sir Gangaram Hospital protocol, where we used just recombinant gonadotropins like we use for all our stimulations, either with LH or without LH. Our doses are 300 units for poor responders, so that we can trigger the growth of even smaller preantral or antral follicles, which we may have missed seeing on the ultrasound. And then we give antagonist whenever we feel that now it's either 5 days of stimulation or a follicle has started jumping up or LH is increasing. We normally have a flexible protocol for poor responders. And once OPU is done, we used to give 3 blank days and then start the second cycle. But we started medroxyprogesterone after 2 days only, so that there could be no drop in progesterone during the luteal phase. And we gave the patient the same FSH or FSH plus LH, whatever we've decided, and medroxyprogesterone acetate 10 milligrams. And then here we could give any trigger we wanted. Agonist would have worked because this is a PPOS protocol, or HCG would have worked, or a dual trigger also works. So whichever way the first cycle's oocytes are, if there are more immature oocytes, we like to give a dual trigger. So that is what we would do with this. Now, type of trigger, I just told you, either it is GnRH agonist or it is HCG or dual trigger. Now, GnRH agonist trigger is the most commonly used trigger in follicular phase stimulation and luteal phase stimulation of diostim to promote early luteolysis, so that corpora lutea do not interfere with follicular assessment in LPS or in even subsequent cycle when the patient comes for frozen embryo transfer. We used HCG also. And where did we use HCG? When we were not sure whether we will have to go ahead with duostim. They were patients who were young, who had poor response earlier, who had like a okay AMH. There were older patients who had a good reserve, and hence we had counseled them for duostim, but we told them that if we can, for younger patients, if we could make 3 good blastocysts, we may not go ahead with the duostim. And for older patients, if we could make 5 good blastocysts, we may not go ahead with the second stimulation. But yes, we would wait for the aneuploidy report if we did a PGTA. So for us, this trigger does not appear to interfere with follicle monitoring in LPS. I'll tell you why. Because in PPOS protocol use, the first ultrasound can be done directly after 13 days. We used a 3-day gap, but I think it is more sensible to use a 5-day gap, because by the 5th day, you know the blastocyst conversions of all your oocytes which you have collected in the follicular phase. And hence you start your stimulation from there. Your stimulation will be 2 days less, which we realized after we compared our paper with Ubaldi's and Vericilli's paper. So 5 days gap first after either the decapeptyl trigger or the HCG trigger. And then we just give them 8 days of gonadotropin and we tell them come back on the 9th day. Go on taking the injection with 1 tablet of medroxyprogesterone acetate. So 13 days gone, mostly all the corpora lutea which had formed in the follicular phase have disintegrated by then. So it was very easy to do our ultrasounds and we could see all the newly emerging follicles. Dual trigger equally used in the luteal phase for trigger because there is nothing to follow up unless you're going to do another stimulation following the duostim, but we've never done that. So dual trigger can be used. Now, gap days. Number of gap days between first OCR and start of next stimulation differs in most studies. So I told you about the protocols, the mild stimulation and the conventional stimulation. Then I told you about the trigger. Now we come to gap days. Number of gap days between first OCR and start of next stimulation differs in most studies. And some of the mild stimulation studies which I had showed had a gap day of 1 or 0 days. Like they picked up the eggs today and they started stimulation maybe 1 day later or 2 days later. Gautam, please. So these are generally studies which have used mild stimulation protocols. So, but then, all of us have found that luteal phase is 2-3 days longer than the follicular phase. After 3 days, we have done. And we looked at someone else's paper also, which was 3 days. But then we found the best was luteal stimulation after 5 days, which was in Ubaldi's paper, Alsberg paper, and Verili's paper. Verili and Ubaldi are from the same team, but different clinicians. So 5 days gives you that extra confidence that you have made or you are making blastocyst. Maybe some blastocyst will be made on day 5, some on day 6, but you can continue the medroxyprogesterone. And we saw that the number of days, now we use it after 5 days, and we've seen definitely our luteal stimulation has become shorter by 2 days. The long 5-day gap between two stimulation is beneficial. I also told you that the utilizable blastocyst and the phase becomes shorter. So what are the merits of duostim? Improvement in IVF outcomes, increased chances of live birth by significantly increasing the number of oocytes and utilizable embryos per menstrual cycle. I'll tell you one transfer which either fails and there are no more embryos left or leads to a miscarriage, takes the patient back by 6 months. They take 6 months in bouncing back. First, the miscarriage, they would do repeated ultrasounds to see every week. Shayad, the bacha bar jaye. Or eventually they'll take maybe medical treatment for aborting or a suction evacuation. Then they get 2-3 months of psychological comeback, and hence it really takes you back by a lot. So if you already have embryos, your age is increasing every day. 6 months have taken away the reserve of 6 months. So it is good that if we can have embryos, we have better outcomes because there is increased chance of live birth by increasing the number of utilizable embryos per menstrual cycle. Utilizable embryos are the ones which you have preserved. Better performance in LPS. A lot of studies have shown better performance. There could be equal performance or even lesser ones. But there is recruitment of more synchronized cohort of antral follicles in LPS due to, I'll tell you why there are more. See, this patient has been exposed to gonadotropins and hence high levels of estrogen during the whole follicular phase. Now, we all know that a long gonadotropin exposure, high estrogen exposure, might have surfaced some of the pre-antral follicles into the recruitment phase of antral follicles. And hence, when we start stimulating in the luteal phase, these small follicles, which have already converted from pre-antral to antral follicles, start growing in the luteal phase. So even if we don't see small follicles while doing aspiration, it doesn't matter because this prolonged exposure to high estrogen levels and gonadotropin helps a new cohort of pre-antral to convert into antral. And two is increased sensitivity of FSH receptors in the granulosa cell by gonadotropin stimulation of the preantral and small antral follicles. So sensitivity of the FSH receptors also increases in the granulosa cells. Reduced patient dropout rates. I just told you in poor responders, dropout rates from IVF treatment are higher after the failure of a single IVF cycle, especially when no eggs or embryos are obtained. In our study, LPS was able to rescue 70% of cycles in which no embryos were formed in FPS. It is not this that every LPS will make embryos. Sometimes FPS makes embryos and LPS we get no embryo. So there are lapses, but already if they've made 1 or 2 embryos in the follicular phase stimulation, they're so eager to go into LPS. And those who have not made definitely run into LPS because they want some embryo to be made. Only after 2 cycles fail, then probably the thing starts sinking that, I have no eggs, I may make no embryos. And the oocyte embryo competence is comparable. It doesn't matter whether you use PPOS protocol or you use antagonist, whether there's progesterone in the circulation which would be there in every luteal phase, but embryo competence does not reduce. And last of all, I told you PPOS in the luteal phase makes a lot of sense. And that is what we thought of and started giving medroxy. We already use medroxy for all our donors for IVF. So we also used it in the Diostim. And it is so patient friendly, just 1 tablet a day, no monitoring, no injections. And the patient comes after 12, 13 days only of injections because we know they will need so many days of injection. We've already seen their follicular phase. And it also prevents menstruation. What are the demerits of this? One is lengthening of LPS. So if LPS in our study was longer by 1 to 3 days, but then in other studies, it was as little as just 1 to half a day. 2 is high cancellation rate in LPS. Compared to FPS, cycle cancellations are higher in LPS due to no response. In our 22% was the cancellation rate in our studies, where you've stimulated for 8-10 days, you don't find a cohort which has grown, you just say, okay, stop. So they do waste injections, but then they've given 2 trials of stimulation. Menstrual bleeding during LPS, a lot of studies have reported this, but we overcame it by using PPOS in the LPS instead of antagonist protocol. Then there's mandatory freeze all. We have to freeze all. There's no way we can transfer because if you've given a HCG trigger in the follicular phase, you can still transfer in that cycle. But if you are using a GnRH agonist trigger, then the endometrium is not optimum for transfer and you will have to freeze all your embryos. Lack of well-designed studies. Currently, there are no large, robust study except of the Vericilli, the one reported by Vericilli, which has the largest number. Randomized controlled trials, analyzing the effectiveness of Diostim. We also need studies on cost effectiveness analysis of this protocol. Having said that, I would also want to bring newer stimulation protocols for poor responders, which have emerged in the last 2 years. Around the time when our study was published, a protocol came up as BiStim. Now here what they do is 1 follicular stimulation and then next follicular stimulation. But this was Massini et al. Did it in 2023. If you read this, it is quite skewed because here what they did was they just froze. They didn't freeze in this. They just made embryos in the first and then they said, let the menstruation comes and we will stimulate you again in the next cycle. So this we were doing for many years, that we used to, reduce the cost of the second cycle when patient came in the immediate next cycle to have stimulation. So we've just started this comparison. One of our fellows have started and we don't find much difference in Diostim versus BiStim. However, 2 menstrual cycles are gone. And in BiStim protocol, in the second cycle of the stimulation, one can also have the option of fresh transfer. But then that fresh transfer option is also in the first stimulation. So the dropout rates in BiStim are significantly higher. And this study was challenged by Ubaldi et al. You must read the study. You must read the challenge, which is so genuine and so good. And here I'll tell you, they did another thing. Okay. They sort of counsel the patient that if they made enough embryos or they made a good embryo, they might transfer. And a lot of patients were tempted even after 1 good embryo were formed, especially the younger patients. So maybe in the long run, BiStim might also prove out to be good, but it will eat away 2 cycles of ours for stimulation. Now, there is another third protocol which has come up, and this is Duostim Fresh. The first stimulation starts in the luteal phase for oocyte collection. Now, what they do is they say, no, we will not spend more time. We will only do it within 30 days. We will start stimulation in the luteal phase for oocyte collection, and we will vitrify all the oocytes. Then we'll do a second stimulation after 5 days in the subsequent follicular phase. And then we will we'll thaw all the oocytes, and then they make embryos, and whichever best embryo is formed, a fresh transfer of the best embryo is done. So the only advantage of Duostim Fresh is option of fresh transfer available, but then 2 cycles are gone. This is Raka et al. Published in Human Reproduction, because first cycle you did it in the luteal phase, second you did in the follicular phase, and then in that cycles luteal phase you transfer the embryo. So ideally 2 cycles are gone here also. In Duostim also follicular luteal, and in the next one you're doing a transfer. That's going to be a frozen transfer. In Duostim Fresh, you have an option of a fresh transfer and freeze all the other oocytes. So however, probability of obtaining higher number of oocytes and embryos in the luteal phase, which was seen in studies using the conventional Duostim protocol, is not seen in this study. They said that they received the same number of oocytes because there were no high E2 levels. There was no gonadotropin stimulation in the follicular phase of those 10, 12 days where new antral follicles could emerge in the luteal phase. So possibly that was the reason. So coming to the end, I would conclude to say, of all women undergoing IVF, protocols for normal and high responders are very well delineated with the aim of reducing complications and optimizing results. So for normal responders, we are not worried. For high responders, we are not worried. We reduce the dosage, we give agonist trigger, we freeze all, and we do not let the patient go into OHSS. And multiple pregnancy, anyone can reduce by doing a single embryo transfer. In poor prognosis women of advanced maternal age and low ovarian reserve, search for an ideal protocol to optimize results and achieve successful live birth still continues to date. We are all looking for the best protocol. These women have less time also because of their age to achieve a live birth. And every time an unsuccessful pregnancy or an unsuccessful attempt of IVF takes them forward by 3 to 6 months to come back for a second cycle. And the problem goes on multiplying. As a result, burden of going through another stimulation cycle leads to a huge dropout rate in these women, or they all opt for donor eggs. In our country, donor egg is still easy to get, but not in all countries. And donor egg takes away the whole genetics of the woman. In today's world, where empowerment of women is being done, donor egg is not taken very kindly. Maybe we can convince some less educated women, or I would say less empowered women, or women who just think very, very sort of casually about their gamete being replaced for donor eggs. But there is a subset of female population who does not agree at any cost. A lot of women coming from the south do not agree for. So take-home message is 2 stimulations within 1 menstrual cycle is proving to be a good tool to accumulate embryos in the shortest possible time and is also reducing dropout rates significantly. Pre-IVF counseling is a must to be able to make these girls understand. And once they understand, they sometimes go through 2 duo stimulations. They are so tempted, to collect embryos. We tell them, you are young. We already have 2 or 3 good embryos. Go through a transfer. They say, no, I want more. I don't want to go through this again. In women undergoing PGT for genetic disorders or aneuploidy, this protocol appears suitable for embryo pooling. And in most studies on Duostim, number of utilizable embryos are more in LPS than follicular phase stimulation. This advice in reverse stimulation, such as luteal followed by follicular, which is Duostim Fresh, or 2 subsequent follicular stimulation protocols. However, we need more robust RCTs to substantiate the effectiveness of Duostim protocol as an ideal protocol for this group of women undergoing IVF. And one more thing, you should have a very good vitrification program if you are undertaking Diostim. If your frozen thaw rate of embryos which are frozen at your center is less than 99% or less than 98%, this is not the right protocol for you because precious embryos in freezing and thawing process. Having said that, I'm just giving you one life lesson. Bethicalism. I would want all of you to answer, what do you think this ism is? Like nepotism, like Hinduism, like Jainism, like Buddhism? Is Bethicalism? Anyone could answer? I'm at the end of the program, so let us. Yeah, who said that? Who said that?
मैम आपकी स्टूडेंट निशा
Yeah,
मंगल.
who said it? Oh, wow, Nisha, this is so beautiful. I yesterday, and I thought this was such a beautiful sentence or word to be said. Be ethical, Bethicalism. So
Ma'am,
this
you
is
taught
what we
me
need
the
to
same.
follow. So whatever you do, you have to be ethical. You have to be transparent. You have to tell the patient what is involved in what, and give her literature to study. Give them, if they are educated, everything. So with this, I finish my talk. And if you have any questions, we have 20 minutes for questions. Nisha, loved your answer. How many people knew this answer? Anyone else knew the answer? Lovely. I learned it yesterday. Smriti, so it can be ethical. Very good. Bethicalism. So any questions, Bhavani, from anyone?
Yes, ma'am. Dr. Pratibha Singh is asking, can PPS protocol be used without gonadotropin for stimulation in follicular and luteal phase?
Without gonadotropin? Like, what would you want to use? Clomiphene citrate? No, you cannot use it. Acha, Gayatri Satpati said, cannot hear you properly. Did everyone else be able to hear me or no?
Ma'am, voice was very clear. I think there must be some
Ma'am, we
Okay. Okay. PPOS protocol, you have to understand the basics of PPOS protocol. We're giving progesterone to suppress LH. How will the FSH grow in that cycle? By clomiphene? No, it will not act. What does everyone say in this?
True, ma'am.
What is
Ma'am,
everyone's
Shalini here.
opinion? Give me the logical. Huh? Someone can answer this question? What will you use, Pratibha, for stimulation? Clomiphene or letrozole?
Ma'am, Disha here. I'm sorry, ma'am. I do use clomiphene with dufeston for stimulation in follicular phase. I give 100 milligram of clomiphene throughout the cycle, and
Okay.
starting from
Okay.
second day of the cycle, I continue giving clomiphene 100 milligram, and
Yes.
then I monitor the patient. I continue giving dufeston 10 milligram BD or
Why?
Meprate 10 milligram HS, either of these
Why?
things. Once my follicle reaches 14-15 millimeter, I try to get a LHE2 done. If my LH is rising at this point of time, I add NTAG. But once the NTAG is added, Clomid
क्या
will
कर रहे हो?
not act.
Gonadotropin कहाँ है? Have you given gonadotropin or not?
No gonadotropin. Ma'am.
So listen, just a minute, Nisha. Let me just stop you here. Clomiphene alone is enough to suppress the LH surge if you give it continuously till the trigger. You don't need to give dufeston. You don't need to give antag. You need to give nothing. But if you give clomiphene till the last day of the trigger, I have no experience that how many follicles will form and.
Ma'am, 2 to 3. 2 to 3 only.
Great. So these are the mild stimulation protocols, which we have
Yes.
also used for our donor.
Yes.
And even 50 milligrams of clomiphene is enough to simulate 10 milligrams of any type of progesterone
Yes,
or
ma'am.
the antagonist. You
But
understand?
ma'am, in poor ovarian reserve patients, sometimes clomiphene alone is not sufficient to suppress the LH. And at that point of time, if we add the NTAG, then we have to give gonadotropin. There is no other way because clomiphene will stop acting. So
No, but you're saying you give dufeston also.
yes, that's why I give dufeston, because dufeston, if my LH surge has started,
Okay.
then the dufeston will not act. So that's why I start giving dofestrone from the third day of stimulation with clomiphene. Hello, ma'am, can you hear me? Dr. Bhavani, can you hear me? Ma'am's video seem to be frozen.
Yes, ma'am, you're audible, but I think ma'am ka kuch network problem.
Okay.
So why don't case series also? I can. Who's
Ma'am,
frozen? I'm
आपका
frozen.
कुछ थोड़ा network
मैम
issue
आपका ना सुनाई नहीं दिया.
अच्छा, network तो बिल्कुल full strength. Sorry, I'll say again, Nisha.
Yes,
If
ma'am.
you've done even 5 or 10 such cases, please bring out a series in some journal, maybe in our IFS journal only.
Ma'am, I'll
But
do.
you write a 5 or 10 series.
Yes, ma'am. Yes,
Please
ma'am.
do it.
Yes,
Write the
ma'am.
protocol, write the number, and it has to be very honest.
Yes, ma'am. It is honest
कितने eggs
only. Yes, ma'am.
बिल्कुल बढ़िया.
हाँ.
And it would be very nice, Pratibha, you've got an answer that PPOS protocol can be used without gonadotropin for stimulation in follicular and luteal phase. I have zero experience about it. Nisha, who's a very good
Ma'am, I
IVF
have had a
specialist,
live
has
babies also. The only thing is that you cannot expect more than 2 or 3 eggs. Maximum, rarely 3 eggs. Otherwise, 2 only.
okay, right. So, Pratibha, you've got the answer from
Yes, ma'am.
Dr.
Yes, ma'am.
Pratibha?
Because I have heard from many, they do stimulation with clomiphene and add
Okay, so we use clomiphene for sort of enhancing the stimulation, reducing the gonadotropin dose, and when we use it till trigger, we use it to suppress the LH surge. But if Nisha has used it and she's got a live birth, I would be very glad if she could publish and we could learn from her. Maybe some patients who absolutely cannot afford IVF and we are doing it in whichever in the general OPD, we can probably do that for low responders.
Yes, ma'am.
And also in poor patient, ma'am, those who are not affordable, we can use this protocol.
But then you
Ma'am.
reduce your IVF cost by half, Nisha.
Yes, ma'am. Ma'am, it is actually very good thing for poor ovarian reserve patients
Correct.
where you have 1 or 2 follicles only.
Okay.
Those patients we are giving 300, 375 international unit of gonadotropin, still we get
Right.
2 eggs.
Yes. But I'm talking about duostim,
Yes.
where the luteal phase gets better number of oocytes only because of the constant exposure to gonadotropin
Yes. Yes.
and the high E2 levels. Both the things give us better follicular
Yes, ma'am.
cohort. But what you are saying in a simple stimulation, and if this works, I would be very glad to try it on some of my poor responders.
Dr. Priya is asking, in poor ovarian reserve patients, will agonist trigger despite low E2 levels affect the oocyte quality in
No.
FPS?
Agonist trigger does not affect if it has really triggered the LH surge. You just have to make sure that the LH levels are high. If you want to do that one day after the trigger, you can see. And if LH levels are high, then it will lead to best oocyte quality because it leads to a trigger of LH with a little FSH also. And both the things are required for maturation of the oocyte and good quality of the oocyte.
Dr. Priyanka Arya wants to know, what if the embryos formed in FPS are of very poor quality? Should we be going ahead with LPS?
Yes. One-sided poor quality embryos do not tell you that this patient is going to have always poor quality embryos. How would you justify? You do another cycle for her, or you will change her to donor eggs. So I don't think that if one can you hear me? Bhavani, can you hear me?
Yes, ma'am.
Dr. Bhavani, can we keep others at mute? Ma'am's voice.
Yeah, I can hear so many voices that I didn't know who could hear me. Shalini, can you hear me?
Ma'am, you are audible. You are clearly audible.
So what I feel is that
Ma'am, we
decapeptyl
can
trigger.
hear you, but there's a lot of disturbance. Others people are talking, so it's like.
So it is agonist trigger is never bad because it leads to FSH and LH both surge. Yes, if your LH is oversuppressed or there is something which doesn't bring about the LH surge, then only the decapeptyl or the agonist trigger, whatever you're using as leupride, will not be enough. Otherwise, it is good.
Good evening, ma'am.
Good evening.
Shalini here.
Huh?
Ma'am, this dual stimulation we are talking about when we give the decapeptile or GnRH agonist as a trigger. But suppose if we have given the CG trigger in the follicular phase, then ma'am, how do you go about, and suppose no blastocyst is in the HCG trigger is given in the follicular phase.
So Shalini, we do it. We've done it because for so
We
many
can't
patients
hear
we
you, ma'am.
counsel. Can you hear me? Your
Yeah,
voice
yeah.
is also unclear. So maybe
Okay.
it is our cross transmission which is poor.
Yeah.
So, we have given HCG trigger in the follicular phase, thinking that we will transfer an embryo if we get 2-3 good blastocysts. Suppose no blastocyst forms, you don't
Right.
have to worry. You're giving progesterone till day 5. You gave her whatever vaginal progesterone you give, thinking that you'll do a fresh transfer. There was nothing which was formed. You change it to medroxyprogesterone acetate. It will make it easier for the patient because it's cheaper also, and 10 milligrams would be good enough. And you start stimulation on that day. And then look into the luteal phase, how many eggs, how many embryos have been formed. Thoda sa himmat chahiye aage jaane ki. That's all. So HCG doesn't interfere because 5 days of gap and then 8 days of stimulation means 13 days gone after the OPU. Generally, by that time, the
Yeah.
corpus luteoli have all regressed and you can very nicely identify the new cohort of follicles.
Okay. That's. Thank you, ma'am. I wanted to clear on this.
Because you don't call them before 8 days. Otherwise, you'll get confused. So 8 days of gonadotropin, aankh meech ke de do. Because you've already seen in the follicular phase that they've gone for 8, 9 or 10 or 11 days, whichever days. These are poor responders. And poor responders may, whenever you go for minimal stimulation protocol, like Nisha said, you may recover 1 or 2 or 3 eggs and you may get good results also. Though once you've given all these drugs, you always have to cryopreserve your embryos. You cannot transfer in the same cycle. But cancellation rate is very high also. If you get 1 egg, no embryo, or 2 eggs, no embryo, and you've not gone for duostim, then the cancellation rate is high. So possibly minimal stimulation with duostim, Nisha, is a very good option which Kwong et al. Introduced in 2014. And then a lot of people followed minimal stimulation and they did duostimulation with minimal stimulation only because of this, what you're saying, cost effectiveness of drugs becomes
Yes, ma'am.
low, becomes really low here.
Yes, ma'am.
I would be glad because all these have to be frozen in any case. So
Yes,
you
ma'am.
go ahead and do minimal stimulation if they are really, really poor reserve patients. And I would love to try your protocol, but I would not give them so much dufestrone and antagonist. I would just give them 1 progesterone and go ahead with stimulation.
Ma'am, the problem is that in low reserve, the surge sometimes unexpectedly rises.
So that is if the follicular selection is too early. So
Hmm.
start as like we do in the antagonist protocol with a estrogen
Priming, yes.
priming, and then we can give clomiphene like you're saying. I don't know whether clomiphene will work well with estrogen priming or not, but it should work.
It should work. Yes,
should
it should work.
So क्लोमिफेन दे दिया 100 मिलीग्राम दे रहे हो तो बहुत अच्छा डोज है और देते रहो लास्ट तक वही सर्ज को रोक देगा अगर बहुत ज्यादा देना है तो बीच में एक बार प्रोजेस्टेरॉन भी शुरू कर दो या whichever time just 1 progesterone a day. Dufestrone is very expensive. I don't like to use it. Medroxy is much cheaper. रोज एक गोली दे दो. That should be able to. It helps all our donors. So low responders may, like you're saying, that sometimes it can escape. So we can do a LH after 5 or 6 days of giving them.
Yes. मैम मेप्रेट आई ट्राइड बट मेप्रेट के साथ बहुत ज्यादा सप्रेशन हो जाता है मतलब some the follicle will become like the growth will at one point stall, so you'll have to increase the dose or something.
No, but you tell me then you use Dufestrone twice a day, which is a high dose.
Yes, ma'am. Yes, I but just to be, that is maybe I need to do a study to compare single dose with a double dose or something.
Maybe.
Yes, ma'am. Yes, ma'am.
Chalo. Anything else anyone has, and we can conclude.
Dr. Nisha had one more question, that for LPS stimulation at the time of first OPU, do we deliberately leave the smaller follicles so that we can rescue them in LPS?
Yes, one of my consultant tries to do this. But when I'm doing an aspiration, I aspirate all aspirable follicles. Maybe they are 9 or 10 millimeter also, I aspirate them. Because when we do a luteal stimulation, there is a cohort which comes up. I don't know from where it comes up, and Bhavani should be able to tell. She's seen so many cases now. पूरा तुम्हारे सामने at least I think 80-90 cases तो हुए होंगे भवानी.
Yes,
और
ma'am.
or you were there when we started the duostim. है ना? You must have been a PG then. Fellow.
Yes, ma'am. Yes.
So do you leave the small follicles? I know Niti leaves, but do
No.
you also leave the small follicles?
Ma'am, maybe the less than 10 mm, but usually a new cohort comes up in LPS. So even if we don't leave,
Yeah, even if you don't see anything, a new cohort comes
yeah,
up.
a new cohort will come up. Usually, many a times we don't see anything.
Yeah.
And a fresh
And
cohort
still
is there.
after 8 days, when you call them, oh, you are so delighted.
May I say, ma'am?
Yeah,
Ma'am, these
sure.
smaller follicles at times, these 9-10 millimeters, or even these 10-12 millimeters, they are mobile, you know, at times you try to puncture them, they don't get punctured,
You
ma'am.
are very right.
I don't know, this is
These
my
follicles,
experience.
very correct experience in very mobile ovaries.
Yeah,
You must always go
yeah,
for small follicles when you've done one larger follicle and your needle is in the ovary. Then the ovary will not move so
true.
easily. So don't try to go
Uh,
individually, taking out your needle and taking another prick. You will never be able to reach the
yeah,
small follicle. So always,
yeah,
go from one follicle to the other. And when small follicles are left, don't leave the big follicle. Don't leave the ovary. Just try to manipulate the
yeah.
needle into the other follicles. You might
You
be
know,
able
I
to.
asked the assistant also to keep the hand press the ovary from the
With the
abdomen.
needle
Still,
inside, I
ma'am,
don't
at
like the
times
hand.
I find it difficult.
Yeah, if it
Yeah,
is
yeah,
difficult,
yeah,
leave
that is
them.
true, ma'am.
If it is
Not with the
difficult,
needle.
leave them. Leave them. Leave them. Don't worry. I like to take them out.
Yeah,
And everyone knows that when I do a stimulation, 3-4 extra eggs mil jate hain only because of those small
yeah,
follicles.
yeah.
And I asked my embryologist कि भाई इनका बता देना कि mature है कि नहीं, and हमेशा मिलता है उसमें से 50% mature भी निकल आते हैं. So we do all the aspirable follicles, whatever is easy for
Yes,
you.
ma'am. We
Don't
did
prick
a
the ovary
study.
extra. Don't prick the ovary
Yeah.
extra for the small follicles. Let them grow in the luteal phase.
Mm.
Dr. Nisha Vaidya wants to know, do you check any hormones
True, ma'am.
post 5-day gap after OPU?
No. If I'm giving medroxyprogesterone acetate within 48 hours of my OPU, we do not check any hormone. We did it in the beginning. We did E2 levels, and I used to get calls, ma'am, E2 fall kar gaya. Ma'am, ye ho gaya. I said, just ignore it. Ma'am, menses aa gaya. And we used to just close our eyes to everything, go on stimulating, and we got good results. I mean, it's not this that I just closed my eyes. I was very vigilant. But that is when initially I gave antagonists and I said, let's switch over to PPOS. We will stop this high nuisance value menstruation for patients in the middle. Because we used to get calls in the night, हमारे injections चल रहे हैं, हमें bleeding हो गया. So it was very distressing for patients unless you tell them beforehand. Same thing, if we did E2 levels, we found in so many the E2 levels did not rise the way we thought because they were high to start with. Now, when you do on day 3 or day 5, you may not find them that low. They don't rise the way you wanted them. So after 8 days, it's all good. If you want, do a E2, do a LH, do everything. Do we do a E2 and LH routinely on day 8, Bhavani, nowadays?
हाँ मैम 8-day stimulation के बाद तो हम कर रहे हैं
कर
but
रहे हैं,
not
सब कर रहे हैं.
before starting the gonadal.
Yeah, not before starting, not in between. 8 days पूरे हो जाते हैं तो LH भी करते हैं और E2 भी करते हैं, right?
Yes, yes.
और प्रोजेस्ट्रॉन देखने की कोई जरूरत नहीं है बिकॉज प्रोजेस्ट्रॉन तो हम दे ही रहे हैं उनको. So Nisha, that's all. You don't need to check any hormones in this.
Yes, ma'am. Yes, ma'am.
Chalo, I think we've had a good discussion and all of you.
Ma'am, just one last question, not related to duostem.
Okay.
What is your experience with the dual trigger, ma'am?
I
Do
think
you give it?
dual trigger is a very good option if there's no risk of OHSS. It is a good option
Okay.
because एक ने काम नहीं किया तो दूसरा काम.
And what protocol then do you follow, ma'am? Ovitril and decapeptyl, you give 500 Ovitril or 250 Ovitril?
No, 250 Ovitril. Our standard dose is 250 Ovitril. when we give the HCG type trigger. And when we use decapeptyl, it is 2.2 milligrams.
Okay, so when you're giving
Bhavani, am I right?
you
Bhavani?
Yes, ma'am. Yes,
I'm
ma'am.
right, na?
0.2
250 and
milligram decapeptyl and Ovitril 250.
250. So if we give dual trigger, these are the two. If we use single, then either of the two. We don't give
so
any
you're
additional.
using it in poor responders or obviously higher responders we will not use
नहीं,
HCG,
जिसमें
but the normal
normally
responders.
in which we want to do a transfer, we will surely use Ovitril or a
Only, yeah.
duotrig or a dual trigger. But
Okay.
where we think that there is a option that we will go for a dual stimulation, we could give just decapeptyl. Like today, I did an aspiration of a
Decapeptyl.
doctor's daughter-in-law. I won't take the name, who's very known to all of you. So she has a history of PCOS. We gave her stimulation. She was not responding as well, but whatever, we gave her a trigger of decapeptyl because she had come from US and she will go back. So we thought we want to do a second stimulation if we don't have enough embryos, then giving a decapeptyl trigger or agonist trigger would be best. So we do that. Even though we got 14 eggs, I don't know what is the embryo conversion at the end of it. It's very severe male factor infertility. So we'll see what happens. If she makes good embryos, we may not do the second stimulation despite giving her decapeptyl trigger. But otherwise, we will do a second stimulation for her.
Okay, thank you so much, ma'am.
All right.
Nice discussion we had.
It's so good. And Nisha, you have taught us something new. And I would really want to see for really very poor reserve patients, try to give them this. And if we can make follicles and take them for IVF, it would be great.
We are done with the questions.
Yeah, okay. Thank you again. My last thanks goes to our INTAS team who sponsors this call every time we do it,
Thank you,
this
ma'am.
video chatting. Thank you very much for being there, Mr. Dave. थैंक यू ये
Thank you, ma'am.
पेंसिल से मार्क्स एटलीस्ट भवानी के बोलने के बाद बंद हो गए और बनने if I close this presentation, stop share and do again the sharing, they will not come again. Okay.
Bye.
Thank you.
Thank you so much, ma'am.
Thank you.
Bye bye.
Bye.
Now they've gone.
Bye,
They are
ma'am.
gone.
Bye. Bye.
Bye bye. Bye.
Thank you, ma'am.